السلام عليكم ورحمة الله وبركاته. الحمد لله والصلاة والسلام على رسول الله. It's my honor, pleasure to be chairing this session. First of all, I would like to thank the organizing committee for inviting me for this session. Really, this session will be an amazing, excellent session. First speaker in our session, Dr. Walid Al-Bakr. Dr. Walid Al-Bakr, he is an associate professor at Imam Abdurrahman Ibn Faisal University. He's an endocrinologist at King Fahd Hospital, and he is the Vice Dean of Clinical Affairs Medicine College. He has an American and Canadian board certified internal medicine as well as in endocrinology. Our colleague, Dr. Walid, he will speak today about a very interesting topic, the update management in acromegaly. Please, Dr. Walid.
Thank you, Mr. Chairman, for this nice introduction, and I would like to thank all the organizing committee for this amazing meeting. And I hope you found this useful. In the next 20 minutes, I will talk about, management of acromegaly. So the objectives actually, which I will talk about the prevalence of acromegaly. Then I will talk about clinical manifestations of acromegaly, and then diagnostic evaluation of acromegaly, assessing acromegaly comorbidities, and surgical treatment and response to treatment, medical therapy of acromegaly and response to treatment. Okay, so sorry for delay. So my objective of this talk, I will talk about prevalence of acromegaly, the clinical manifestations of acromegaly, diagnostic evaluation of acromegaly, and then I'm going to talk about assessing acromegaly comorbidities, then surgical treatment and response to treatment, medical therapy available of acromegaly and response to treatment, then management approach to acromegaly, and general guideline for physicians. So, as you know, acromegaly, the prevalence is very rare disease. Is about 40 to 50 per million, and the incidence about 3 to 4 per million. And the mean age of onset is around 32 years, and the mean age at diagnosis usually 42 years. So usually there is a delay in the discovering of the disease by almost 10 years. And the prognosis usually 2 times increase in mortality if not treated. So, and the cure rate is greatly reduced if the tumor actually invade cavernous sinuses. As you see that acromegaly have usually associated with multiple metabolic abnormalities. It affects the cardiovascular, the diabetes, glucose tolerance, as well as the musculoskeletal and the respiratory system. You can see from the screen that the acromegaly, because of excessive growth hormone, have an indirect affecting on the impaired glucose tolerance and diabetes. It actually affects the beta cells function, the glucose uptake, and increase the glycogenolysis. It can cause and precipitate diabetes, and secondary causes of diabetes is acromegaly. It affects the RAS system, of renin-angiotensin system, so it will result in hypertension. It results in increased renal sodium reabsorption and increased sympathetic activity. With this diabetes and hypertension, it usually affects the cardiovascular. It causes left ventricular hypertrophy and cardiomyopathy. And because of soft tissue swelling, it results in insulin resistance. Usually it causes sleep apnea. And because of the excessive growth hormone, it increases risk of cancers, especially the colonic cancers. And this is usually the multiple metabolic abnormalities that can be associated with this rare disease. If you see here the impact of acromegaly on survival, you can see the general population in the green color, and you can see with all acromegaly, usual life expectancy decreased by 10 years. And if it is associated with diabetes, even further reductions in the life and the survival, and will be highest if it is associated with cardiac disease. So it is a rare disease, but it is serious if it happens and reduce the life expectancy. and the most common cause of death is actually the cardiomyopathy or heart failure, and also followed by cancers. You can see here the treatment actually have an impact also. The long-term mortality after transsphenoidal pituitary resections, you can see we have the if the patient post pituitary surgery, if you find that the normal IGF-1 compared to elevated IGF-1, you see the survival is reduced if the IGF-1 is still high after surgery, which indicate there is a residual of a growth hormone excess. This actually correlated with decrease in the survival. This what tell us as a physician that is important. This is rare disease. Yes, it is important to discover it because this disease associated with the multiple comorbidities and interference with the treatment, it definitely improve survival of the patient. The acromegaly actually, when they present actually to the clinic, they might present with local complication because of the pituitary mass. So the patient might have headache, might have a vision problem, visual field defect, and maybe ophthalmoplegia. And that's why referral can come from a neurologist because of the headache, or it comes sometimes from ophthalmologist because of the vision defect. Also, in the other side, the acromegaly, they can present clinically with signs and symptoms of excess of a growth hormone, which we're going to talk about it, mainly headache, sweating, change in shoes and ring size, a change in the face textures. Also, in the other side, because of this big pituitary mass, can be also causing pituitary insufficiency. So panhypopituitarism can be associated because of the Stark effect. So lethargy, weakness, fatigue, hypogonadal symptoms also it can happen. So always teach the fellow that they should actually, when they screen, they should screen for the function of the pituitary function, whether hyperfunctioning or hypofunctioning, and the symptoms of compression. So the acromegaly signs and symptoms, you can see the growth hormone excess, the enlargement of the hand and feet, thick skin, skin tag, sweating, sleep apnea, also carpal tunnel syndrome is important. And as you see, that sometimes you get referred from neurologists because of the carpal tunnel syndrome. Osteoarthritis can happen, and it could be tumor related, and that because of the headache, because of visual field defect, or symptoms of, as I mentioned, pituitary insufficiency. There's pictures of acromegaly, and you can see a typical acromegalic face, also acromegalic hands. This acromegaly was discovered since long time, many decades ago. This is in the extreme left side is pictures in the museum of David and Goliath, which showed that acromegaly discovered even since actually many decades. So this is a patient who is actually at age of 28 started to have acromegaly, and then this is how his face changing up to age of 65. And definitely there is actually a late discovery of acromegaly, because the features of acromegaly, a lot of actually people misinterpret it as changing because of the aging rather than because of the disease itself. This is again another picture of a patient, evolution over 20 years, which show that the acromegaly changing in the actual pictures of this young lady, and show the acromegalic face. So there's definitely late actually discovery by physicians. This is one of the things that can patient discover is, and the physician actually screen by changing in the shoe size of the patient with acromegaly. Also, change in the ring size also is a manifestations of acromegaly. Change in the glove size, hat size also is a clear actually screening that we do for when we talk and we take history from acromegaly. They have a classical acromegalic hand, acromegalic feet, and they have a brocanthism and typical frontal pausing, and that's why we always ask them to get an old photo, and we compare the current photo with old photo. This is actually malocclusion of the jaw and wide space teeth, a crowded teeth. This is actually also another pictures of that happens. Sometimes we get referral from a smart dentist because of this tooth problem. Skin tags, and I have one referral from one dermatologist who faced a patient with multiple recurrent skin tags, very significant, and he has a subtle features of the acromegaly and referred to my clinic. So the skin tags, it could be a manifestations of the growth hormone excess or acromegaly. Acanthosis nigricans also could be, in addition to type 2 diabetes and Cushing, also can happen with acromegaly. Carpal tunnel syndrome, we get referred sometimes from neurologists for unexplained actually numbness, tingling sensation both hand with large hand, and this can be a manifestations of acromegaly. It could be also compressions for the eyes. Yes, if it is an optic chiasm, it typically causes the bitemporal visual field problem. Remember, headache with visual field, it can think of pituitary adenoma. So this is the pictures where you can see the pituitary mass, how it actually affects the optic chiasm and result in visual field defect. Frequently, we got that actually from and refer from ophthalmologist. So in a brief for our colleague also in primary physicians, the acromegaly key point, which can provoke and help you to suspect acromegaly if there's multiple skin tags with acanthosis nigricans, excessive sweating, wide-spaced teeth, carpal tunnel syndrome, change in shoe size and ring size. Probably need to think about this. History of secondary diabetes, hypertension, osteoporosis, you have to think of this possibility. So as a physician, as endocrinologist, we always, when we look to the acromegaly, we suspect based on the KK features, then we start to screen, then we confirm, and then we localize by doing an MRI. In this sequence, this is the way we think. So when you do random basal fasting growth hormone and IGF-1, so we've used actually, if you use ultra-sensitive assay of growth hormone, less than 0.4 microgram per liter, and normal IGF-1 acromegaly usually ruled out. On the other side, that if you growth hormone more than 0.4 microgram per liter and elevated IGF-1, then actually this, it might reflect that there is a possible growth hormone excess. So what we do a growth hormone during oral glucose tolerance test. What we know that if you give actually glucose to a patient with acromegaly, it's supposed to, if in normal person, it should suppress the growth hormone. But in acromegaly, it failed to suppress the growth hormone. So if it is more than 0.4 microgram, then the diagnosis of growth hormone excess confirmed, and there is actually most likely an acromegaly, and you start to go a stage of localizations of the tumor. Or OGT, this is how we do. We admit the patient on actually short stay. We actually do 0 time growth hormone, and then 60 minutes, and then after 2 hours, and then we actually measure the growth hormone response to the glucose at 75 gram, and we see it's supposed to, a normal person, to suppress as in control, you see in the pictures, but in acromegaly, it failed to suppress to less than 0.4, which confirmed the diagnosis of acromegaly. So the next step is actually localize of the tumor by doing an MRI, and the MRI will localize the tumor, and the MRI is not only it helps us to localize the tumor, but also if it can indicate whether we are dealing with small microadenoma less than 1 centimeters or more than 1 centimeters as macroadenoma. Also show us whether it is invading the other cavernous sinuses or not. The bigger the mass, the less respond to surgery, and the more residual and recurrence that can happen after surgery. But if it is smaller, the more I can respond to surgery. Also, some MRI criteria like hyper intense in MRI view, it might reflect that this patient might not respond very well to a surgery. Then after you confirm, and I ask the fellow always when you confirm diagnosis of acromegaly, you have to screen the comorbidities. Cardiovascular, looking for blood pressures, echo, ACGs, respiratory, by sleep study, and you do the fasting insulin, the oral glucose tolerance. You screen for A1C and diabetes. Also, you actually do X-rays for the joints and bone density sometime, and you might do colonoscopy for cancers. So hypertension happened in 35%, 29% is sleep apnea, 18% diabetes, headache 17%, and carpal tunnel about 24%. It can happen with acromegaly. There's a picture with acromegaly with the sleep apnea and how the soft tissue swelling, it can cause this acromegaly. And this usually improves after surgery. This is how the acromegaly can be associated with the colonic polyps and increased risk of colonic cancers. And usually the higher the insulin growth factors, the more risk for colonic cancers. So the objective treatment, when we confirm and we look to the comorbidities, now what we would like is to control the reverse the symptoms and signs. We have to suppress the growth hormone and IGF-1 to control the morbidity and mortality, decrease pituitary tumor size, control the tumor mass effect, and preserve normal pituitary hormone function. This
5 minutes, Dr. Walid. 5 minutes. Okay.
Sure. This picture will show that to you, the microadenoma, and you can see the macroadenoma. The response actually, as you see it in these pictures, microadenoma response about 80 to 90% and macro 40%. You can see the radiotherapy, the response to radiotherapy about 50%, but happened at 10 years. Octreotide up to 50%, 40% with cabergoline, bigivusimab is 95%. So the main treatment is actually surgery, transfemoral pituitary resection, but because there might be residual, so you might need adjuvant treatment like using the somatostatin analog and also sometime the dopamine agonist or growth hormone receptor blocker. Remember, these factors is important. Histology is sparsely granulated, MR to hyperintensity, high Ki-67, high baseline growth hormone, and large tumor volume, and increased tumor size. These things predict the response to treatment. The response to treatment depends on the experience of this neurosurgeon, the adenoma size, the invasiveness of the adjacent structures, and the preoperative growth hormone. This is show you the response is better with microadenoma if you do surgery for micro compared to macroadenoma. And again, different from one center to other, but you can see the majority of micro response in 80s, but in macros in around 40 to 50s. Remissions actually after, it depends also adenoma size. The bigger the adenoma size, the less response post-operatively, and the more need for has transfemoral sections. Also growth hormone, so persistent abnormal growth hormone suppression is associated with an increased risk of recurrence. This is a new update of if you have a patient after 12 weeks after the acromegaly transfemoral pituitary section, you have to evaluate by doing OGT. The first line treatment actually is starting with still octreotide or lenalidomide with somatostatin analog. Or if the patient is not responding very well, this is called partial responder, that more than 50% decrease in the growth hormone or IGF-1, you can increase the somatostatin dose or increase dose frequency, or you add cabergoline to somatostatin analog. You can see here, if no control and there's a tumor concern, you can use a very good new medication called pasireotide. If there's no control and there's impaired glucose tolerance, you can use bigivusimab because pasireotide, it causes increased glucose intolerance. If it is not controlled and tumor concern and impaired glucose metabolism, so you can give third generation somatostatin analog plus bigivusimab. Again, if it's controlled, you monitor. If it's not controlled, you might actually do surgical resection. So oral octreotide, it has been used in phase 3 and is upcoming maybe in the near next 2 years. There's a study actually by Dr. Musa Al-Malki from Riyadh, is most recent published in Hormone 2020. And this is a clinical feature therapeutic outcome with acromegaly in Saudi Arabia. You can see total of 195 patients with mean age. They screen actually a 195 patient chart in 9 major hospitals. They found that acromegaly age average about 43 plus minus 12 years in male and 46 plus minus 14 years in female. And this is from 9 major hospitals. They found that is 92% were macroadenoma, headache, coarse facial features, acral growth, and sweating were the most frequent presenting complaint. The most common comorbidities were diabetes in 51%, followed by hypertension 50%, visual field 30%. 95% of the patients were treated surgically, and 24% also received radiotherapy, and 74% received medical therapy. When strict criteria were applied for assessment of outcome of therapy, 28% of the patients were cured, 30% had their disease under control, while 28% were found to have active disease in spite of receiving multimodal therapy. I want just to close here. The key point to remember about acromegaly, the disease control criteria is normal age and 6-IGF-1. Also, random growth hormone level less than 1 nanogram per ml, and a growth hormone suppression test after 75 less than 0.4 by using ultrasensitive assay. This should be done 12 weeks after surgery. Remember, 10 to 20% of acromegaly are somatostatin resistance, and the predictor of that are sparsely granulated adenoma, lack of the SSTR2 expressions, and high Ki-77 proliferation index. Remember, pasireotide is a second-generation somatostatin analog that have 40 times effective compared to octreotide, and normalize IGF-1 in 20% of resistance cases of the first generation. But the problem, have a higher rate of hyperglycemia, so avoid it in diabetic patient. Bigifosfamide, it blocks the growth hormone receptor. A dose-dependent normalization can be achieved in 90% of the cases at a dose of 40 milligrams per day, but you need to watch for hepatotoxicity. IGF-1 normalized both optimally in about 80% of microadenoma and 50% in macroadenoma, and risk of hypopituitarism is 10 to 15%. Remember, tumor growth is invariably arrested with radiotherapy, but the decline in growth hormone and the clinical improvement are slow in 20% per year, and hypopituitarism is very high and seen in 50% within 5 to 10 years. Cabergoline is good medication, could be used, and monotherapy result in biochemical control rate of approximately 35%, and similar benefit have been seen with addition of cabergoline to somatostatin with inadequate actually control. So the benefits are largely, we found it if the IGF-1 about less than 2.5 times the upper limit of normal. There is a new suggestion from acromegaly expert that use acromegaly disease activity tool, which will provide an objective measurement of acromegaly signs and symptoms, comorbidities, tumor profile, growth hormone level, and IGF-1, and we recommend that we can use it to assess and monitor this disease. So I think that to conclude, and sorry for delay, the recommendations actually, this should be in high, to treat acromegaly in high specialized center, in that include expert endocrinologists, as well as a neurosurgeons, histopathologists, and neuroradiologists should be center of excellence. This is Dr. Connie Chick. I have honored to be with her. She was awarded as a pituitary expert award in Canada, and with a center of excellence. I want to conclude the famous Shrek pictures is actually inspired from a true story for a person who was actually acromegaly, born in 1903. Remember, beauty is deep inside. Thank you for a nice listening.
Thank you very much, Dr. Walid, for this exciting, comprehensive updating about acromegaly. I really enjoy it. And I think the message for our colleague in family medicine to catch any of those signs or stigma of acromegaly and refer it to endocrinologists. And this is the most important step. Thank you very much, Dr. Walid, for that. Thank you very much.
Thank you very much.
Now we will move to the second lectures with our colleague, Dr. Saad Al-Zahrani. Dr. Saad Al-Zahrani is a consultant of diabetes and endocrinology. He is the medical director, obesity, endocrine, and metabolism at King Fahd Medical City. Dr. Saad, he will talk today about the update management in hypothyroid. Dr. Saad, the floor for you.
Assalamu alaikum. Thank you very much.
Alaikum salam.
Do you hear me well?
Yes. Yes.
Okay. So the slides are okay, Abu Umar or Sean?
Yes. Yes.
طيب
Very
بسم
nice.
الله والصلاة والسلام على رسول الله. Thank you very much, Dr. Awad, for the nice presentation. Thanks for Dr. Walid for the informative lecture. I would like also to thank Dr. Saud and Mr. Abdul Munim for inviting me and all the organizing and scientific committee of this course. I'm going to speak today about the management of hypothyroidism. I think my presentation will make more sense for you than Dr. Walid, who precedes me. So inshallah, talk about the management of hypothyroidism, and we'll touch the most important points, as this is a very long topic. So I'm going to talk about the normal TSH, what is the normal TSH, and I'll talk about the causes and the consequences of hypothyroidism. And then we'll talk about few tricks in the levothyroxine therapy. Then we will touch an important clinical issue, which is persistent of the hypothyroid symptoms with normal TSH. What can we do for such patients? Then we'll talk about subclinical hypothyroidism. If we have time, I have a few slides about hypothyroidism and pregnancy. So what is the normal TSH? The normal TSH is the lab reference range. Whatever your lab is telling you about the reference, it is the normal value for you, for you, because the kits usually are checked with control people. But we usually tend to have a normal of less than 5, or some other literature are mentioning even lower than this of 4.1, although this is a very controversial issue. But what we usually use is the 5, or what is the lab reference is telling you about. The TSH is relatively stable with different set point in normal people, and there are so many factors affecting the TSH level that includes the age. We know as we get more aged, our TSH is going higher because our metabolic rate is slowing, and this is like a physiological reaction to the body with aging. Ethnicity, there's different ethnicity, different TSH levels, iodine intake, and the presence of autoimmune disease, as we are going to see. So this slide is showing that what I have mentioned earlier, that the TSH increases with age, and you can see the upper limit of the normal is increasing with age, while the lower limit is usually stable. And as you can see, if the patient age is more than 70, the 5.5 تقريبا of TSH is normal. If 60, the 4.55 is normal. And sometimes we are using the an easy approach that if the TSH in a 50 years old person is 5, this is fine. If the TSH is 6 in 60 is okay, 7 in 70, and 8 in 80. So we should not overreact, especially in older patients. We should not start treatment if we find TSH unless it's very clear hypothyroidism with low free T4. Because if you start unnecessary T4, you are going to subject the patient to unnecessary atrial fibrillation, cardiac problems, and also sometimes to osteoporosis. So how can we classify hypothyroidism? We usually classify it depending on the pathology. If it is primary, coming from the thyroid itself, we call it primary, and it is consisting of about 90% of the cases. Usually we do have high TSH and low serum free T4. And if the TSH is high with normal free T4, we call this subclinical hypothyroidism. Secondary hypothyroidism occurs when the serum T4 is low and serum TSH is not appropriately elevated. So either it is low or normal. It's not getting up to match the low free T4. So we call this central or secondary. The subclinical, I have mentioned about it, normal free T4 and elevated TSH, and we'll have a few slides about this. The clinical manifestations of hypothyroidism, I think it's clear for most of you. there will be a slowing of the metabolic processes. There will be fatigue, weakness, cold intolerance, dyspnea, sometimes weight gain. In kids, they might have mental retardation, constipation, growth failure, and some other characteristic finding, like slow movement, delayed relaxation phase of the reflexes on the signs. So this, as you can see in the symptoms, it's a bit like vague symptoms. It's not very specific. So you'll find a lot of causes of fatigue or weakness, like anemia or vitamin D deficiency or low calcium. All can cause this this problem. So you have to have a wide differential diagnosis first. Then you go and diagnose hypothyroidism. You will not find all these symptoms and signs in the patient, but sometimes you have a good clinical sense, and you might ask for TSH and you find some abnormalities. The other clinical manifestation is due to accumulation of matrix substance like dry skin, hoarseness of voice, edema, and on the examination you might find coarse skin and preorbital edema. The others, like decreased hearing, myalgia, menorrhagia, and those with hypothyroidism, they have more tendency for bleeding, while those with thyrotoxicosis, they have more tendency for coagulopathy. They might also have arthralgia. They might have also pubertal delay in kids. So again, this is how to diagnose it. We have talked about this. When the TSH is high and free T4 is low, you are dealing with primary hypothyroidism. If both are low, we are dealing of secondary hypothyroidism. This is coming from the pituitary gland. What investigations you need to do? Of course, if you consider hypothyroidism in your differential diagnosis, you should do the thyroid function test. Sometimes TSH alone is enough for screening, and unless if you suspect a central cause, but TSH is enough for screening. But what we do usually is that we order the TSH and the free T4 in most of our patients, and I'm sure that you are doing the same. Here, a very important point that you consider repeating. Always repeat in endocrinology and hormones. You know, the assays are different from lab to another, and if you want to start a patient on lifelong treatment, you need to have a good proof of the problem. So always consider repeating. Also, you might need to do the thyroid antibodies. TBO being the most sensitive serologic tests. Also, you can do the TG antibodies, and you need the antibodies in cases like subclinical hypothyroidism or pregnancy that might tell you whether to start the medication or not. It's very important to make the decision of treatment. You might need to do lipid profiles, especially cholesterol and triglycerides. Usually it becomes high in patients with hypothyroidism. You might need to do an ultrasound. You don't need to do it in all patients, but you have to have, you need to examine your patient. If you find a nodular goiter or a goiter, you need to do an ultrasound to confirm the presence or absence of the nodules. If you find the nodule, you can send the patient to endocrinologist, especially if it is more than 1 centimeter, and especially if it is like hypoechoic with irregular margins or presence with calcification, especially central calcification. This needs to be referred to endocrinologist. You need to sometimes do LFT because hypothyroidism is associated with NAFLD, non-alcoholic fatty liver disease. Sometimes you need to do CBC because sometimes it's associated with macrocytic anemia. Electrolytes is also, you can do it because sometimes it's associated with hyponatremia. And of course, other autoimmune disorders like type 1 diabetes, like Addison, pernicious anemia, vitiligo, all is associated with hypothyroidism. Usually the autoimmune disorders do cluster in some patients. So when the patient comes to you and you diagnose hypothyroidism, you have to go through all this to make sure that he doesn't have another autoimmune disorder. If you suspect another autoimmune disorder, you should screen for it. What are the causes of hypothyroidism? In iodine deficient areas, iodine deficiency is the most common cause. In the iodine sufficient areas, the most common cause is Hashimoto's thyroiditis, represent more than 90% of the cases. And usually it is an autoimmune in nature, and up to 80 to 90% of the patient, they will have anti-TPO positive. Usually it resolves to normal. Usually if Hashimoto's thyroiditis is diagnosed, usually it's a permanent problem. The other cause is the subacute thyroiditis dequervins, usually caused by a viral cause, and usually the patient present with painful thyroid gland, and usually most of the patients, they do resolve to normal within 12 to 18 months. The others, like silent thyroiditis, postpartum thyroiditis, they do usually, sometimes they present with thyrotoxicosis, then followed by hypothyroidism, but most of them, they do resolve. Those caused by drugs like amiodarone, lithium, interferons, they usually resolve after discontinuation of the medications. Those like caused by radiation are usually permanent, and very rare cause of thyroiditis or hypothyroidism is suppurative thyroiditis, and usually they do resolve after treatment with antibiotics. So when we treat with a thyroid hormone, we should target a serum TSH in the normal range for replacement therapy. And higher TSH levels should be targeted for elderly. So as we have mentioned, don't overreact for older patients when they have a high TSH. LT4 dose is influenced by age, weight, and lean body mass, and severity of cardiac disease, etiology, and pregnancy. So if the patient is overweight, you find that you might need a higher dose. If he's losing weight, the dose might be needed to be reduced. And we have seen this with those patients who undergone bariatric surgery. We usually reduce the dose, and I have few patients we stopped the L-thyroxine. Thyroxine dose requirement is less for primary hypothyroidism compared to the central or post-op or post-radiation. So keep this in mind that if the cause is primary hypothyroidism, Hashimoto's, the dose is lower. Thyroxine dose is 1.6 to 1.8 of the per kg for the actual body weight. Patient initially treated should have a TSH measurement at 4 to 8 weeks till you have a steady and a normal range TSH. Thyroxine should be taken 30 to 60 minutes before breakfast, or if the patient is preferring to take it at night, he can take it 3 to 4 hours after the PM meal. The usage of thyroxine alone to treatment is the recommended way now. So we only use LT4. There are some preparations of LT3, LT4, but the recommendation is to use only LT4. When initiating treatment in older than 50 to 60 years patients without coronary artery disease, thyroxine dose should be 50. So don't start big dose in older patients, because you might push them to ischemic heart disease because thyroxine increasing the metabolic rate. TSH should be repeated 4 to 6 weeks after any change in the dose. So whenever you change the dose, you have to bring the patient back in 4 to 6 weeks to check the thyroid function. Longer periods of TSH testing can be used in patients with stable dose and weight. And each visit, you have to check for signs or symptoms of over-treatment. Also, you have to check for the compliance, because the compliance issue is very important, especially in our society. Cardiac patient, you should start very small doses. Sometimes we start with 12.5 or 25 micrograms according to the severity of the heart problem. You have to keep in mind that some medication can reduce the absorption, like calcium, ferrous iron, ferrous sulfate, sucralfate, and vitamins can reduce the absorption. Medications that increase the metabolism, the CYP 450 metabolism, can decrease the bioavailability of LT4, like phenobarbital, phenytoin, carbamazepine, sertraline. And also, if you give a patient a high dose and you didn't find a good response, you should check for celiac disease, malabsorptive problems, sometimes gastritis that might prevent the absorption of thyroxine. So why do some patients with hyperthyroidism continue to complain despite normal TSH? You have to think about non-thyroidal illness like vitamin D deficiency, calcium, vitamin B12, anemia, sometimes fibromyalgia syndromes. Sometimes patients, they might have chronic fatigue syndrome. This might be a cause of the fatigability or weakness that the patient didn't improve after they are taking the thyroxine. Thyroxine dose inadequate. You have to make sure that the patient is taking it in a good timing and keep a good time between the intake of the tablet and the meal. Sometimes there is a need of combination of T4 plus T3, and there are other explanations like depression. Depression is a great mimicker for hypothyroidism. They do have sharing symptoms like constipation, decreased concentration, decreased libido in men, depressed mood. So always think about depression if your patient is not improving with the adequate dose of thyroxine. When we have such patients, sometimes we do make some changes in the thyroxine doses, but in this study, it didn't show any benefits.
So, Saad, 5 minutes to run. 5 minutes.
Okay. So in this study, it didn't show any change in the significant effect of the treatment on any of the instruments for well-being, symptoms, quality of life, cognitive function, or treatment preference if you increase or decrease the thyroxine dose. In fact, this study was done, for example, to manipulate the TSH from like 4, it is within normal, but they bring it down to 3. Sometimes we think if we bring it to between 1 and 3, this might be beneficial to the patient and this might improve the symptoms. But in fact, it didn't. This study didn't show that there is any improvement of this. Sometimes we do a combination of T3 and T4, although it's not recommended. But as I presented this, that just show you that some patients do prefer to use a combination of T4 and T3, although the outcomes in the clinical studies didn't show a difference. But the patient preferred the combination than the free T4 only, or L-thyroxine only. Then we'll move to the hypothyroidism with low TSH, or what we call a central hypothyroidism. As we have mentioned, those patients, they do have low free T4 and inappropriate low or normal TSH. And there are a lot of causes of this. For example, if the patient has a pituitary or hypothalamic tumor, lymphocytic hypophysitis, which is an inflammation of the pituitary and hypophyseal area, Sheehan syndrome, surgery, radiation to the pituitary gland, all of these can cause central hypothyroidism. In patients, central hypo assessment of free T4 or free T3 is needed, not the TSH. So if you diagnose central hypothyroidism, you should follow the patient with free T4. You should make sure that the free T4 level is within the normal range. Additional tests you can do is like you should check for other pituitary hormones and check for you do an MRI to make sure there is no pituitary mass. And the treatment is usually the same as the hypothyroidism, but they usually require higher doses. What about the subclinical thyroid disease? It was referred as the biochemical evidence of thyroid hormone deficiency in patients who have few or no apparent clinical features of hypothyroidism. So when you check the thyroid function test, you find the TSH is high and you find the free T4 is normal. So this is what is called by subclinical thyroid disease. And there has been a special criteria for treatment of such patients. As we have mentioned, 80% of the cases, TSH is between 5 and 10, which make it more, the dilemma is more problematic. TPO antibodies present in 60 to 80%, and are most likely positive in those with higher TSH. Sometimes it's referred as mild or early hypothyroidism. The causes are the same as overt hypothyroidism. Autoimmune thyroid disease, the most common, treated hyperthyroidism, postpartum thyroiditis, LT4 treatment, head and neck radiation, drugs like lithium amidalone, and other autoimmune diseases. What are the consequences of subclinical hypothyroidism? They might progress to overt symptomatic hypothyroidism. They might have bad symptoms like fatigue, mood, excess weight, the other complications like high serum cholesterol, and the controversial issue of cardiovascular morbidity and mortality. And I have presented these studies to show that some studies have shown that patients with subclinical hypothyroidism, they might have incident chronic heart disease in 2 studies, but the others didn't show this finding. Subclinical hypothyroidism is associated with NAFLD, which is the non-alcoholic fatty liver disease. 1% of patients with NAFLD, they might have cirrhosis, so it's a serious problem. So let's have an approach to subclinical hypothyroidism. How many minutes, Abu Umar, I do have?
Almost 1 minute more.
So I will finish with the this approach to subclinical hypothyroidism. So you take first the serum TSH. If you find the TSH more than 10, you immediately start treatment. And I want to stress to the point that you need sometimes to repeat the test in some patients to make sure that you are dealing with the right lab results. If the TSH is between 5 and 10, you need to repeat the TSH 3T4 TPO antibodies in 2 to 3 months. Except if the patient is planning to pregnancy or if she is pregnant, then the decision to start to have a different approach for such patients. If you repeat the test in 2 to 3 months, the patient came with normal tests, you just follow. Usually the follow-up is in 1 year. If the TSH and TPO antibodies are positive, you treat if the patient has goiter, hyperlipidemia, infertility. Young patients, you keep low threshold to start the treatment, or pregnancy or planning for pregnancy. So routine treatment is not recommended when TSH level are below 10. Any elevation of TSH must be sustained for at least 3 months. Treatment starting with low doses of T4, 25 to 50, and there is a risk that the patient will progress to overt hypothyroidism, particularly if the TSH level is elevated and TPO antibodies are positive. I think I have to stop here and let me conclude here, just half a minute. Hypothyroidism is a common disorder which can lead to several morbidities if not treated well. Hypothyroidism is associated with multiple biochemical abnormalities that should be addressed based on clinical presentation. Hypothyroidism with persistent symptoms, but normal TSH represent a management challenge. Subclinical hypothyroidism is a common finding that should be treated in young childbearing ages. Thank you very much.
Thank you very much, Dr. Saad, for this nice, comprehensive presentation in a very common topic. I know it's very hard to cover it in 20 minutes, but Dr. Saad did actually. Thank you very much, Dr. Saad. Now we would move to the third speaker, Dr. Adnan al-Sheikh. He's an associate professor of pediatric and associate dean at King Saud bin Abdul Aziz University for Health Science, National Guard in Jeddah. He's a consultant pediatric endocrine at King Abdul Aziz Medical City in Jeddah, and he has a Canadian fellowship of pediatric endocrine from University of Toronto. Dr. Adnan, he will talk a very interesting topic. He will talk about the rickets, the diagnosis, and update management. Dr. Adnan, the floor for you.
Assalamu alaikum wa rahmatullah.
Wa alaikum assalam wa rahmatullah.
Thanks a lot, Dr. Awad, for the introduction, and I would like to thank Dr. Saud al-Sifri and التيم في الجمعية العلمية للسكري for arranging this educational activity online. Thanks a lot. My topic is rickets diagnosis and management. So this is the outline of my talk. I will talk about vitamin D metabolism and then the rickets types and diagnosis and treatment. And then a very interesting study we did on vitamin D in Saudi Arabia. So bear with me, I hope the time will be enough. So let me start with this question as a stimulating to the group, to the audience. Which one is an essential finding in all types of rickets? I will give just a few seconds to think. So I will just answer now. So maybe a lot of you will know that it is the hypophosphatemia. This is really the most consistent finding in rickets. Look at this table and it will show you. You can see that really the low serum phosphate is the most consistent finding in all types of rickets. With that, I will start with the metabolism of vitamin D. So the main sources of vitamin D in the body is either diet or from the skin through the ultraviolet. And then it will be metabolized by the enzyme 25-hydroxylase in the liver to make 25-hydroxy vitamin D, and then it go in the kidney and metabolized by the enzyme 1-alpha-hydroxylase to do the active or to make the active 125-hydroxy vitamin D, which work on the receptors. So the daily requirement of vitamin D, according to the American Academy of Pediatrics, is about 400 to 800 units. And if you think of the food content of vitamin D, there is really very few amount of vitamin D in most of the natural foods, and except for the fatty fish like salmon and sardines, and maybe also in the liver, and of course in the fortified milk. If you see this table, so the fortified milk, of course, will contain about 400 units per liter, but the salmon and the sardines contain the highest vitamin D, and also the liver and egg yolk. But other foods is really very scanty and small amount of vitamin D. So what are the nutritional habits that could cause vitamin D deficiency? The most common problem is excessive drinking of carbonated beverage like Coca-Cola or Pepsi, which contain high phosphate content, and that will decrease the calcium absorption in the intestine, causing secondary hyperparathyroidism, and that will worsen the phosphate excretion. So the second source of vitamin D is from sunlight, and actually it's through the skin. And if there is inadequate skin exposure, like in infants or elderly, they are more prone to vitamin D deficiency. If you look at the factors which affect vitamin D formation from sunlight, the main factors are the latitude or geographic location and the season, more in the summer than in the winter. Also, if there is atmospheric condition like clouds, smogs, and fogs or dust particles, that will definitely affect the penetration of ultraviolet rays, and also the duration of exposure, and if there is excessive covering. Now, skin color, we are dark skinned people, so most of us will need 6 times amount of sunlight exposure than Caucasian to make the same amount of vitamin D. And of course, now also a common problem, a lot of mothers will keep their infants indoor, and they will expose them to the sun through the window glass, which does not cross the effective ultraviolet rays, will not go through or penetrate the glass, so they are more prone to vitamin D deficiency. But how much sunlight exposure we need? There is a lot of debate about it, but most of the authorities will say about 30 minutes of sun exposure every day to the face, arms, and hands and shoulders will be an adequate for vitamin D. Now, if you are exposed a lot to the sunlight, is it toxic? Can we get really toxicity of vitamin D from sunlight? And the answer is no, because there is really steps which is controlling really that to make the inactive in the skin. It will make inactive products called tachisterol, and also in the kidney it will make the inactive 24-25 vitamin D. So wherever you're exposed to the sun, you will not get vitamin D toxicity. So now let's move to the second part of the talk, which is types of rickets. The most simple classification is nutritional rickets or renal rickets or hepatic rickets. And the other pathophysiological classification, you can divide them into hypocalcemic rickets or hypophosphatemic rickets. The hypocalcemic rickets will have a high parathyroid hormone, and usually they have a low calcium, whereas the hypophosphatemic rickets, they got a normal parathyroid and normal calcium. So let's start with the first type, which is vitamin D related rickets or hypocalcemic rickets. The second one is primary phosphate deficiency. So what are the causes of hypocalcemic rickets? The main cause is vitamin D deficiency or defects in vitamin D metabolism, and because of either decreased intake or malabsorption or inadequate sunlight exposure, or because of defect in vitamin D metabolism like in liver disease or kidney disease. So if you think of back to the main really graph of vitamin D metabolism, so if there is inadequate intake from the diet of vitamin D or inadequate sun exposure, then we'll develop nutritional rickets or what we call classical rickets. If there is defect of this enzyme, 25-hydroxylase, which is really rare, but I saw very few cases, and my colleagues in National Guard Hospital, they reported Riyadh, they reported family with 25-hydroxylase deficiency. Or if there is 1-alpha hydroxylase deficiency that will cause vitamin D dependent rickets, type 1, those children will present with hypocalcemic seizure. Or if there is defect in the receptors, vitamin D receptor, then patient will develop what we call vitamin D resistant rickets or calcitriol resistant rickets, and sometimes it's called vitamin D dependent rickets type 2. So liver causes like obstructive jaundice or use of anticonvulsants because they are enzyme inducers, so it will increase the hydroxylation of vitamin D. Renal causes either if it is inherited like 1-alpha hydroxylase, or if there is a receptor defects in the tubules for the 125, or if there is a chronic renal failure causing renal osteodystrophy. Now, this graph will show you really all of these conditions. So if there is a defect of intake or lack of sun exposure, that will be nutritional rickets. If there is 25-hydroxylase deficiency, it will cause persistent rickets. And if there is a deficiency of 1-alpha hydroxylase, it will cause vitamin D dependent rickets type 1. And if the receptor is affected, it will be type 2. Now, also, if there is excessive phosphate wasting, that will cause hypophosphatemic rickets, and that will take us to this second main category of rickets, which is called primary hypophosphatemic rickets. The main problems are either renal losses or inadequate intake. So renal losses, mainly hereditary rickets like X-linked hypophosphatemia or autosomal dominant or autosomal recessive. These are rare conditions in our country, but it's common. It's actually the most common cause of rickets in Western country. And then Fanconi syndrome with all its conditions. We have a plenty of those cases in Saudi Arabia, or it could be isolated tubular defects like proximal tubular acidosis, or rarely, but it's in pediatric, but it's maybe in adults, you see oncogenous tumor causing a BTH-like tumor that will present with hypophosphatemic rickets, or more commonly in the pediatric population in premature babies, or they will develop rickets of prematurity, or if there is neck with who needed really TBN, or they will develop malabsorption, or if they use a Nucate formula. Now, Nucate is a hydrolyzed, completely hydrolyzed formula, and a lot of premature babies or babies who developed neck or needed surgery, bowel surgery in the first maybe 6 months of life, they will need a Nucate as elemental diet, or they will need it for growth. But unfortunately, it has been proven that those babies will develop hypophosphatemic rickets. So you have to be aware about this really new finding. Now, how to diagnose rickets? Easy, not difficult. As all medical conditions start with history. So if there is a baby with an exclusive breastfeeding or inadequate sun exposure, or no vitamin D supplement to the baby or to the mother, or if the mother came to the clinic complaining that her child did not start to walk yet, sometimes they can present with hypocalcemic seizure. Dr. Al-Alwan and Dr. Ngham Al-Mutair and their group, they reported a study in 2006 of about 283 children with nutrition rickets, and actually 34% of them, they presented with hypocalcemic seizures. So this is not a rare presentation. Now, the other common presentation is metaphyseal enlargement, causing wide wrist or rachitic rosary, or they can present with bowed legs or hypotonia. So this is a baby with rickets who present with large head and wide anterior fontanelle, and also they will develop delayed teething and enamel hypoplasia. This is the rachitic rosary. You can see it very clear in children with nutrition rickets, and also you can see the wide wrist. If prolonged untreated rickets, they will develop really significant deformities of weight-bearing bones or fractures also. And the main presentation of those children also will be bowed legs. You can see the genovarus deformities on those children. Now, if it is untreated, they can develop various body deformities which can persist into adulthood, like genovalgus deformity or genovarus deformities, or genovalgus deformity, what they call knock-knee, with also a lot of lower limb deformities. Now, radiologically, they develop what they call rachitic triad, so widening and cupping and fraying. You can see it very clearly in those X-rays. You can see the widening and fraying in the metaphyseal plate, and you can see also deformities of the lower limbs and generalized osteopenia. And you can see these widening and cupping and fraying, and after treatment it improved. And you can see that this is really an active rickets on the metaphyseal bones. So you will not miss really radiological signs of rickets. You can see that there is generalized osteopenia, rachitic triad head, and also fractures. You can see there is significant really radiological finding of rachitic triad of lower limbs. So in lab, the main finding, as we agreed on in the beginning, that all rickets will present with low serum phosphate, and most of them, they will have a normal serum calcium, but they can develop hypocalcemia at the beginning, or with an advanced rickets, they will get significant high alkaline phosphatase and significant secondary hyperparathyroidism. And also they will have a low 25-hydroxy vitamin D. Remember, this is really the most and the best marker of vitamin D status. So if you want to assess the vitamin D status, do 25 hydroxy vitamin D. Now, in patients with hypophosphatemic rickets, the situation or the lab finding is different. They will get normal parathyroid, normal serum calcium, and also normal 25 hydroxy D, and they got significant hypophosphatemia. The alkaline phosphatase is usually slightly raised, but they have really significant high urine phosphate, and you can do the genetic testing to confirm, but maybe easier to do the fraction excretion of phosphate with this formula. You can easily do it in the clinic, and then you can do this nomograph to calculate the TMB-GFR, which is diagnostic for the hypophosphatemic rickets. And you can do that easily in the clinic. And this is very diagnostic for hereditary hypophosphatemia or hereditary hypophosphatemic rickets. Now, if you find it a significant hyperphosphaturia, then you do the urine dipstick to confirm that it could be Fanconi. So you can, on spot in the clinic, you can diagnose if there is glucosuria or aminoaciduria or calciuria. And if it is suspected, then you have to do further genetic testing and metabolic testing. The treatment of rickets is very simple. You will start them with vitamin D, either drops or tablets. The usual starting dose is 4,000 units. You can give it, as I said, in tablets, or in children more than 10, they can swallow the tablets, or if you can start with the drops daily. Now, we have a lot of problems with the compliance, so we can give the same dose on a weekly, so we can ask them to drink the whole bottle every week. That will give them about 40 to 50,000 units every week. And those with this, and also we call it mini STOS therapy, or you can use the STOS therapy, which is single dose, and you can give it on a single dose. And there is really many patients who are using, who needed this therapy, especially those who are not compliant in adolescent. But please do not use 1-alpha to treat nutritional rickets, and don't forget after healing of rickets to give them the daily requirement, and of course encourage sun exposure and drink more milk. Now, is there really any evidence for giving single dose of vitamin D? And the answer is yes. So I quote 3 studies quickly. I will mention them, that it really work. So the first study in Kuwait, they use really 400,000 units as a single dose compared with the oral, and there is really no toxicity, and there is complete healing. That is done in Kuwait. The second study done by Dr. Prof. Muhammad Ahmed Abdullah in Riyadh, and he treated an adolescent who failed to improve with oral treatment by giving an IM injection, and actually there is no toxicity or side effect. And the last study by Benita and Shah and their team, they give oral vitamin D, 600,000 ergocalciferol in 6 doses every 2 hours, and there is really no side effect. So STOS therapy or single dose can work, and it is there is really no problems with it, but you have to be careful with iatrogenic hypercalcemia, because if some patient, they will take the injection or the dose, and then they go to another physician to take another injection. So you have to be very careful with that. Okay, the second inherited type is called vitamin D resistant rickets. Those are very, very difficult to treat. They develop alopecia totalis, and they have significant bony deformities. And actually, there is a very good trial that those patients actually respond to calcium infusion, but they are very, very difficult to treat. We give it in a central line. Now, hypophosphatemic rickets, the they will respond to the conventional therapy, oral of phosphate and 1-alpha. Oral phosphate is really not tolerable, not tolerated well.
5 minutes, Dr. Adnan. Okay.
Okay, so then I have to be quick. There is a new treatment for hypophosphatemic rickets called Burozumab, and it has been approved, and we have about 18 patients in Saudi Arabia on this treatment. The last part of my talk, how common of vitamin D deficiency in Saudi Arabia. So we did a question, me and as a pediatric endocrinologist, and those group Yusuf Saleh and Dr. Ali Al-Garni and Prof. Baha, to look of is the vitamin D deficiency is common in pediatric and adults. So we screened about 6,000 adults and pediatric population. We did it as a cross-sectional study, school-based study all over the country. We did it in about 9 large cities in 4 regions in Saudi Arabia. The pediatric population was 2,000 in these really 4 regions. And that was our questionnaire. We did 3 things. We did general physical examination for those patients, and we did questionnaire, which is, you know, for the dietary intake and vitamin D, the sun exposure, how much milk, and if they are taking any vitamin D supplement, any, and their demographic data. And also we did the blood samples for vitamin D and bone profile and parathyroid and creatine. And we use the cutoff of the Institute of Medicine, which is less than 25 is deficiency, 25 to 50 insufficiency, and more than 50 is a normal. So these are the surprise. Look at the results. So 95% of our patients had vitamin D deficiency or insufficiency, giving a prevalence of a 95%. So if you look, so in general, the prevalence was 95% for both the deficiency and the insufficiency. If you look at the males, about 64% were deficiency, less than 25 for the females, and the males about 25%. And if you put it together with the insufficiency, it's about 92 and 97%. And then we looked at the risk factors. We found that vitamin D deficiency is more common in Al-Ihsa and Eastern region, more than the Western region, and more common in the female population. And actually, 47 of the Saudi children reported no vitamin D supplement, and actually 25% reported no dairy intake at all, or insignificant, and 29% reported very inadequate sun exposure, and 52% reported less sufficient sun exposure. So in summary of this study, it showed really a very high prevalence of about 95% having vitamin D deficiency and or insufficiency, meaning a level less than 50 nanomole. And actually many other studies, I quote them, showed the same results, but actually more than 80% we found really higher. And we found that the main risk factor is lack of sun exposure, inadequate intake of vitamin D, and inadequate use of vitamin D supplement and covering. So, dear colleagues, in conclusion of my talk, rickets is common finding in the pediatric population. Healthcare workers, including GB and pediatricians and other healthcare workers, need to be aware that this is a common problem in Saudi Arabia, and they need to know the types and the diagnosis and management. The main treatment is really vitamin D drops or tablets. You can use either daily or weekly or STOS therapy, but you have to be very careful. I usually don't do the IM injection. I go with the oral, either STOS therapy or mini STOS therapy. Please do not use 1-alpha to treat nutritional rickets. And as shown from our study that and other groups, that vitamin D deficiency is so common in the Saudi population, in Saudi children and adolescents, up to 95%. In other studies, up to more than 80%. Unfortunately, it's very common in our population, in spite of plenty for sunshine. And we have really, that suggests that maybe we have to do a regular screening of vitamin D. If you break any child for any lab test, I tend to do vitamin D and treat it if it is insufficiency. And I think we have to set up a national program for either vitamin D supplementation or food fortification and or health education at all levels, in school, in the families, or at the media, to prevent vitamin D deficiency in the Saudi population. With that, I would like to thank you for your attention.
Thank you very much, Dr. Adnan, for this nice, excellent presentation. I enjoy it. It's very nice. Now we will move to the last talk in this session. Our colleague, Dr. Saud Al-Sifri, he will talk about the DABA and the heart failure. And as you know, Dr. Saud Al-Sifri is the professor of medicine and endocrinology. He has in the medical school at Taif University. He's the director of diabetes and endocrine specialist Center Prince Mansour Hospital. He's the chairman of endocrinology and diabetes department in Al-Hada and the Taif Armed Force Hospitals. Dr. Saud.
Okay. Assalamu alaikum wa rahmatullah. Thank you very much. Thank you very much, Mr. Chairman, and thank you for giving me. So here we're going to take you a bit away from pediatric and even from those, I would say, either neuroendocrine tumors or those very common endocrine problems, where we would move a bit. So by the way, I'm not a cardiologist, despite I'm going to talk about heart failure. But I think what you're going to see in the coming, I would say, few years, that cardiologists might treat diabetes, and even diabetologists might treat heart failure and other atherosclerotic cardiovascular disease. So it means we are talking about almost the same patient where we share very common things together. In this, very briefly, I'm going to talk about the DABA heart failure. And this is one of the studies which looked into the prevention of adverse outcomes in heart failure trial by using this. So basically what we are going to talk is about the common disease, how we are going to see this study. So I'll give you, I would say, a snapshot of those study, what was the main findings, what was the baseline, and then did it have any implications or guidelines on those results. So let's start with this. We always think that diabetes has nothing to do with heart failure, but if you would look here into among those two kind of populations, where they looked for 4 years follow-up, and they found that those patients with type 2 diabetes, they have got almost 10% of incidence of hospitalization due to heart failure because they were having diabetes. Now, when they compared them to others who did not have diabetes, they have got almost 6%. So from here, there was an increase by almost 1/3 greater risk of hospitalization due to heart failure. So here we could conclude in those almost 45,000 populations whom they had been followed for 4 years, whether they have got a cardiovascular risk or they have got an established disease, that type 2 diabetes is independent risk factors for having heart failure. This is, all of you are aware, this is a cardiovascular outcome trial of dapagliflozin, which is one of the SGLT2 inhibitors, which is declared, where here they looked into 17,000 patients with type 2 diabetes whom they have got either an established cardiovascular disease or multiple risk factors. And in this one, they have got the composite endpoints of 3-point MACE, which is a cardiovascular death or non-fatal MI, non-fatal stroke. And then they have got what they call it a secondary primary endpoint. And in that one, they have looked into cardiovascular death along with hospitalization for heart failure. In those, the composite endpoints were significantly based on using dapagliflozin in top of standard of care compared to those standard of care added placebo. They have got 17% significant reduction of those composite cardiovascular death and hospitalization for heart failure. So from here, we would conclude that in this cardiovascular outcome trial, the secondary primary endpoint, it was met by reducing it only by adding dapagliflozin to those patients on their follow-up. So based on this background, always we would ask ourselves, in people who has got type 2 diabetes, does using SGLT2 inhibitors, dapagliflozin, would prevent the developments of heart failure? Because we knew that dapagliflozin has got what we call it glucose-independent benefits in terms of their glucose control. Now, the second thing, how about those patients who has got an established heart failure? Can we use the canagliflozin to treat those people? So from here, we knew that we would need to study both of those. In patients who has got type 2 diabetes or those who without diabetes, does it make a difference? Can we use what we call it anti-diabetic agents? Dapagliflozin, SGLT2 inhibitor can treat both of them. So from here, dapagliflozin 10 milligram once daily wanted to be tested by adding it to patients who has got heart failure with reduced ejection fraction. So we call it HIF-REF. And those whether they have got diabetes or without diabetes. So let's look at the design of this DAPA-HF study. Here they have randomized almost 5,000 patients from 20 different countries. And in this, it was an international multi-center parallel group where they have got randomized and double-blind trial in those patients who has got already an established heart failure. In this, their ejection fraction was less than 40%, and their, what we call it, brain natriuretic peptide has been high, which indicates that they have got heart failure. Plus, New York Heart Association classification, they have got either 2 to 4. They have excluded those patients in whom it is not indicated to give an SGLT2 inhibitors, those with estimated GFR less than 30 or borderline systolic blood pressure less than 95, or those who has got type 1 diabetes. Then just to remember, out of those, so we have taken all patients who have got reduced ejection fraction and established heart failure, whether they have got diabetes or without diabetes, and we wanted to give them a standard of care for anti-failure treatment. So if you would remember, those are ACE or ARB. It could include even other medications, which is mineralocorticoid receptor antagonist or neprilysin inhibitors, all of them. In top of that, either they would randomize them to receive placebo or dapagliflozin 10 milligram. So what do they want to look for? And this is the primary endpoint. So it was a composite of the 3 points, which is cardiovascular death, hospitalization due to heart failure, or urgent heart failure visit to emergency department. So the composite of this, once it has been achieved, which is the event-driven trial, so it's not limited with the time, it's limited with the events. So the required events were more than 844. Once it was met, those patients, they have looked into those. So here they wanted to have those with brain natriuretic peptide more than 600 picogram per ml. Now let's look at their age. Now here you have to remember those 2 columns. One of them has got diabetes, while the other one did not have diabetes. And if you look at their baseline characteristic, basically they were the same. So most of them, they have got class 2 or 3 New York Heart Associations, and their mean ejection fraction was almost 31. And if you look at their pro-BNP, it was like more than 1,000, almost 1,500. Their blood pressure was maintained. And despite this, their estimated GFR and was 60 in this. Now, for those who has got, I would say, reduced ejection, reduced estimated GFR, they were almost 50%. Apart from this, if you would look at those who had got a prior or history of hospitalization due to heart failure, we're talking almost about 50%. So here we have looked into both groups, diabetes as well as those without diabetes. Now, important to look at their diabetes, at their anti-failure treatment. So if you would see here that most of them are taking diuretics, and again, more than almost 95% taking either ACE or ARB. And again, if you talk about beta blockers. So if you would see here, they were equally distributed among diabetes and no diabetes. And the second thing, they were well treated with or maximum treated with anti-failure measures. Now, let's look at the primary outcome. And if you remember, it was the composite endpoints of cardiovascular death, hospitalization due to heart failure, or urgent visit to emergency department because of heart failure. Now, if you look into the left side, those are with diabetes. And here there was significant reduction by adding dapagliflozin on top of the standard of care compared to those who received placebo on top of standard of care by almost 25%. And this was very significant. Now, how about those people who did not have diabetes? Did it make a difference? And the answer came yes. 27% significant reduction by using dapagliflozin in top of anti-failure measures once it is used dapagliflozin. And this was very significant. So from here, we would say that the primary composite outcome has been met, and it was superior reduction by using it. And it did not make a difference whether this patient is having diabetes or without diabetes in this. Now, the component of this, if you look into cardiovascular death, again, numerically, it was better with dapagliflozin, but again, it did not reach a very significant level. But again, it tells you whether diabetes or no diabetes. Again, using dapagliflozin has got a numerical reduction in cardiovascular death without significance in this. Now, how about those with worsening their heart failure, i.e. that they would need an urgent admissions? Here you would see that it was 23% significant reduction in people with diabetes by using dapagliflozin. And again, here almost 38% significant reduction even for those who did not have diabetes. And this was very much interesting. Now let's see whether, does it make a difference whether they have got diabetes or no? And again, if you would see whether that population has got diabetes or no diabetes, addition of dapagliflozin 10 milligram once daily on top of standard of care has got a significant reduction by 25 to 27% in both arms in terms of their cardiovascular death and hospitalization due to heart failure. So in this, they wanted to include whether it was first time or it was a repeated hospitalization. So it is important to see the time for the first hospitalization due to failure or the repeated time. And again, here we are talking about whether patient has got diabetes or no diabetes. Again, it is almost like the same with this, adding dapagliflozin 10 milligram either in people with diabetes or no diabetes has got a very significant reduction in terms of their time for the first or repeated hospitalization by almost 27 to 23% in those populations. Now, this is just to see, this is one of the questionnaires where we will look into those people who has got heart failure in terms of their symptoms. So in this, it was consensus So this is Kansas City cardiomyopathy questionnaires, where the total symptom score is going to be measured, where it is a change of more than 5 points. Now, if you look at those with the red on the left side, again, those people with diabetes, definitely adding dapagliflozin has got a better improvement and even less deteriorations in terms of their symptoms. Now, the second thing, when you look at people with diabetes, again, there was an improvement by adding dapagliflozin compared even with less deteriorations by not adding dapagliflozin. Now, an important thing is always we wanted to make sure that there would be no harm on kidney. And here they have measured the composite of both in terms of their renal function. It is what we call it a month sustained more than 50% reduction in the estimated GFR, or what we call it end-stage renal disease in terms of their estimated GFR, or death due to renal cause. And again, if you would see here, in all of them, whether patient is having diabetes or no diabetes, definitely adding dapagliflozin has got a better outcome or a reduction in their renal function outcome, despite that it did not reach a significant level. Now, all-cause mortality, again, for people with diabetes, there was significant reduction by 22%. And again, here, for people without diabetes, the all-cause death has been reduced numerically, but it did not reach a significance. Now, we wanted to see, does it make a difference whether your patient is having hemoglobin A1C, which is more or less? Now, for people with type 2 diabetes, now, if you would see the unity line here, when we talk on the left side of the unity line, then it means we are talking about those who has got benefit by adding dapagliflozin. So here, if you would see whether people has got diabetes, you would see definitely there was significant reduction in terms of their benefits by almost 27 to 25%. Now, again, for those who has got without diabetes, so there is no diabetes, despite this, they have got a benefit despite touching this. So numerically, it was better, but it did not reach significance because it just touched the unity line. Very important, because here we talk about totally a different trial. So this was the first trial to look into heart failure outcome with dapagliflozin in terms of their outcome, and in this, whether they have got diabetes or no diabetes. So the main concern really for us, is it safe to use it for people without diabetes? Because we knew in diabetes that most probably there was no much deteriorations. Now, if you would look at those in diabetes on the left side or without diabetes, and if you would compare those, I would say, adverse events of concern, you would see that volume depletion or renal adverse events, they were equally in both groups, whether received dapagliflozin or placebo. And again, in those discontinuations were even the same, whether they have got this. Now, one thing I just want you to remember, that there is a major hypoglycemia, and this was for us was a concern. Does it have any hypoglycemia risk in people without diabetes? I think if you would see from here, you would find that no, there was no major hypoglycemia in those without diabetes. And even in diabetes, they have got a very low rate, and this was comparable whether they have received dapagliflozin or they have received placebo. And the explanation behind this, that they were using sulfonylurea or insulin, which increased the incidence of this. Now, again, there was no safety signals from this. So for us, this was more reassuring. Now, we would expect, again, more and more publications to look from this DAPA-HF. So again, you would find that almost in every 1 or 2 months that they would have more publications where they would look into subgroup of populations. Now, just remember here, we are talking about those people with heart failure with reduced ejection fraction. So So here we are not talking about those with the preserved or high ejection fraction. So this was
3 minutes to run, Dr. Saud.
Okay, thank you. So I'm almost on time. So now we would go into, did this results of DABA-HF had any significance in terms of their implications on guidelines? So I think if you look on the consensus algorithm of the European Society of Cardiology along with the European Association of Study of Diabetes, you would find that in those patients who has got an established atherosclerotic cardiovascular disease or very high risk, in those it has to be added either an SGLT2 inhibitors or GLP-1 receptor agonist with a proven efficacy. For those who had been using metformin, once they would need addition of treatment, you have to consider those based on the aggregation. Now, how about those who had been already on metformin? Again, here this was, I would say, very brief guidance that in those patients with an established disease or whom they have got a very high risk, even if they were on metformin, you have to add an SGLT2 inhibitors or GLP-1 receptor agonist with a proven efficacy. And for those who had been already without any of those risk or disease, then you could continue with the metformin. Again, I just want to highlight that in this, they have categorized those patients with atherosclerotic cardiovascular disease or heart failure or chronic kidney disease. And in that, it is only 2 medication which has been approved after metformin. This is from the European Association of Study of Diabetes along with the American Diabetes Associations. In those situations, if the atherosclerosis is more predominant than GLP-1 receptor agonist followed by SGLT2 inhibitors, while if heart failure or chronic kidney disease are more prevalent, then in that situations, you would use any of those SGLT2 inhibitors with proven efficacy. So the benefit has been already for those patients with heart failure, and always you have to consider your patient. Now, this is the FDA approval. So from US FDA approval, apart from using it as anti-diabetic agent, it has got the approval for using it for heart failure in order to reduce the cardiovascular death and hospitalization for heart failure in those people with an heart failure with reduced ejection fraction. And in that populations, it has been approved. Definitely, we should not use it in patients with type 1 or those with DKA. So, Mr. Chairman and dear colleagues and audience, this is the final, just to conclude that when we are going to add dapagliflozin in top of standard of therapy, then we have to reduce the risk of worsening heart failure events and cardiovascular death, and that would improve the symptoms by a meaningful in patients with reduced ejection fraction heart failure, either they have got diabetes or without. The reduction in the composite of cardiovascular death and hospitalization due to heart failure was very substantial and very significant, and this was consistent in both groups of people, whether they have got diabetes or no diabetes. The good thing that dapagliflozin was well tolerated, and the rate of treatment discontinuation was very low, either in people with diabetes or without. So here, I think dapagliflozin is another new approach in the treatment of heart failure with reduced ejection fraction in patients either with diabetes or without diabetes. And with this, really, I would like to thank you. Thank you very much.
Thank you very much, Dr. Saud, for this nice presentation. Now, I think we will move now to the discussion. We have a couple of questions for our eminent speaker. We just would like to start with the first speaker, Dr. Walid Al-Bakr. Dr. Walid with us?
With you now.
Okay. Just regarding your just talk, we have a couple of questions. The first question, do we need to treat the acromegaly with hormone after surgery of developed growth hormone deficiency?
Actually, the problem is basically the patient having growth hormone excess, and most of the patient actually, they have residual of the tumor post-op. So we don't usually give a growth hormone for a patient with acromegaly even after surgery. What we need more is to control more, the growth hormone and the residual tumors. So, and the long-term cure is really difficult and need really a lot of adjuvant treatment.
Sure. The next question is for Dr. Walid. There are some studies like DeMarchi has studied in 2002 who suggest 25% of acromegaly patients may have a normal baseline of growth hormone. Is there any cases you have seen with normal basal growth hormone levels?
Well, if you go over the literature, yes, there growth hormone, it can be normal in some of acromegalic patients. So the best screening actually we do is the IGF-1, but it can happen. So growth hormone can be affected with a lot of confounders, like, fasting, like meals, like also have adrenal variations, stresses can affect, medication can affect. So it's not a good marker that always we rely on to diagnose acromegaly. Normal, it doesn't rule it out, and high doesn't rule it in. So this is a very important as physicians when you look at the growth hormone. So yes, for my experience, I have probably a couple of patients, but I don't have some of them. Most of them, they have high growth hormone. I don't know my colleague if they have some cases with normal growth hormone and acromegaly.
Sure. The last, just if you highlight about the ACR-OD80, which is the acromegaly disease, I think, tool activity.
Actually, if you compare the consensus guideline for acromegaly in 2014 to the new one, which was in 2018, the new thing they introduced actually something called acromegaly activity index, where it is actually a tools. They use it to monitor patient with acromegaly post-op. And this is actually constitute of five factors. One is the IGF-1 post-op. So this is actually the most important. Second is the tumor mass itself. Again, the tumor bulk and the tumor volume, and it's based on the MRI follow-up. And the third thing is the comorbidities of the patient, like diabetes and hypertension. And the number 4 is the symptoms of the patient complain with like headache or like, carpal tunnel and others. And the last is the quality of life. And this can carry a scoring system where you can use it actually to follow your patient post-op. Still, this kind of system need more validation, but it's still is a good one that we can use it for following our patient and see whether we need to optimize the treatment and increase the dosage or change the frequency or add on a medication to assure control of the patient. So, this, I think, the new things that we use it for our patient now to monitor them post-op.
Thank you, Dr. Walid. I think this is your part. I don't have any further questions. From my side, I really appreciate, I enjoy your presentation. Thank you for your time. Thank you for your participation tonight.
Thank you. Thank you, Dr.
The questions for Dr. Saad. We have from the questions, I just received it. Is hypothyroid curable?
Depends on the cause of hypothyroidism. If the cause is, like, for example, Hashimoto's thyroiditis, or it's due to radiation, or of course, surgery, it is not curable. But if the cause is, for example, the subacute thyroiditis, Quervain's disease, or some other autoimmune thyroiditis, like the painless type, or the postpartum thyroiditis, there is about 80% chance of cure, and about 20% of these patients might continue to have hypothyroidism. Those who drug-induced, usually they do have the hypothyroidism while the drug is there. Once we remove the impending medication, most of the patients will have like a cure of hypothyroidism.
Thank you, Dr. Saad. Does the pregnancy induce hypothyroid?
So the short answer is no, but we know the pregnancy is a high metabolic rate. So the whole body, the whole physiology of the body is set to have a high metabolic rate, and one of them is the one of these mechanisms is the higher thyroxine and lower TSH in the body that increase the metabolic rate of the body. If the patient is having a pre-existing thyroid problem, it's going to appear more in the pregnancy because the requirement of L-thyroxine is going to be higher in the pregnant lady.
Another questions in pregnancy and thyroid from the audience. Do we need to stop the levothyroxine in a subclinical hypothyroid in a pregnant lady after delivery?
I mean, one of the most difficult situations that we might have in the clinics is to stop L-thyroxine, but to make it easier for the one who asked the question, what we do usually is we depend on many things. For example, the presence or absence of the antibodies, the dose of the thyroxine during pregnancy, and as I have mentioned, the etiology of the hypothyroidism. So if the patient, for example, was on dose of like 25, of course, after pregnancy, we can stop it immediately, and we can repeat the thyroid function test in 6 weeks. Even the antibodies are positive. So dose of 25 can be stopped. If the patient is in 20, for example, in a dose of 50, what we usually do is we give half of this dose, and we repeat the test in 6 weeks. If the patient, for example, was diagnosed with overt hypothyroidism, we usually give 2/3 of the thyroxine postpartum, and we do usually repeat the test in 6 weeks. So what we need to do is you have the dose, and you ask the patient to come in 6 weeks. You recheck. If it becomes in the normal levels, you can stop. And again, even if you stop, you have to bring the patient back to repeat the thyroid function to make sure that the no recurrence of hypothyroidism. If the antibodies are positive, it's going to be really difficult to stop the thyroxine because the pathogenesis is there, the causing the inflammation is there. So you expect that these patients are going to continue to have hypothyroidism. So we do keep low threshold to stop thyroxine in such patients.
Thank you very much, Dr. Saad, for your nice presentation, for your excellent discussion. I don't have any more questions for you. We really appreciate your participation, and thank you for your time as well on behalf of our colleague in the Congress. Thank you very much, Dr. Saad.
يعطيك العافية عمر.
الله يحفظك. شكرا لك. دكتور عدنان أبو محمد.
تفضل.
You have a couple of questions, if you don't mind. When we are expecting correction of bone deformity and rickets, and when we have to refer for ortho.
Thank you, Dr. Awad. Very good two questions. This is a metabolic changes that happen over months, actually. So for the treatment, it will take months. And also the deformities, I will say it needs 6 months to maybe 12 months until it is completely corrected. So don't be in a hurry that it will resolve quickly, and then you will ask for another treatment or another maybe injection of vitamin D. You have to wait. When to refer to ortho? If the rickets is inactive, meaning the markers are normalized, then this is the time where you refer. And it's actually wrong to for the orthopedic to touch the patient and do any surgery in a patient with an active rickets. Then deformities will be even worse, and actually healing will be less.
Thank you. Another question is, can I give vitamin D regularly to kids for prevention of ricket if no sunlight exposure? And for how long?
Yes, yes. This is actually the recommendation. So if there is no sun exposure, then infants and children has to take vitamin D. Remember that very few vitamin D is available in the food. I'll just remind you, we need 400, or when children, they need 400 units of vitamin D. How they will get it? Tell me one child will drink 1 liter of milk. There is no children will drink 1 liter of milk. So if they will drink 1 cup of milk, that will give them 200, actually 100 unit of vitamin D. So definitely any child who's not exposed to the sun, they should be taking vitamin D supplements. And the second part of the question is for how long? I would say until they drink enough amount of milk, or if they take fatty fish, مثلا, for example, or to continue as a maintenance of about 400. I would usually recommend to take, let's say, the daily requirement in a week. So take it in a week. Now there is 5,000 units vitamin D. You can take it every week or every maybe 2 weeks. And also in adolescent now, I give the 50,000 units of vitamin D every month as for the daily requirement or for prophylaxis. And yeah, that's, you are saying for how long? So this is maybe the answer.
Excellent. Thank you, Dr. Adnan. I don't have any further questions for you. We really appreciate your excellent presentation, your participation in this night. You and our colleague make our night. Actually, on behalf of our colleague in the Congress, we really appreciate your participation in our events. Thank you very much.
Shukran.
Shukran. Now for our colleague, senior colleague, Dr. Saud.
Thank you.
We have some questions for you before we release you.
Thank you.
Okay. Okay. As you know, the question that we have, the DABA heart failure is one of the landmark actually study in diabetology as well as in cardiology. So the questions we have is DABA increase the rate of amputation in diabetes with diabetic foot? The second questions, can we use DABA in patient and with heart failure without diabetes?
Okay. All right. So I thank you very much. And I think this is the DABA heart failure trial is really an outcome trial, which looked into heart failure, whether those they have diabetes or no. And the good thing, when we looked at the adverse events and the safety profile of those populations of almost 5,000 patients, there was no increased risk of amputation in those, whether they have got diabetes or no diabetes. But here we have to mention that always in those people with diabetic foot, try to minimize the use of the class of the SGLT2 inhibitors, or you have to use it with the precautions in those with an established diabetic foot. But there was nothing from the trial towards this one. Now, the second question is, can we use
DABA in patient with heart failure without diabetes?
Okay, this is a very good, and this is exactly what the trial has answered, that in people with diabetes or without diabetes, but with heart failure with reduced ejection fraction, definitely adding dapagliflozin in top of the anti-failure measures has got a significant reduction in terms of their cardiovascular events and hospitalization due to heart failure. So the brief answer, yes. In those with reduced ejection fraction, yes, it is clear. There are other trials now which is looking into those DELIVER and others, which looks into the other category of people with an established heart failure with preserved ejection fraction. So we are still waiting for that result.
Okay, what is the risk of DKA when you're using DABA?
Okay, thank you. These are difficult questions. Now, again, when they looked into the population which has been studied in the dapagliflozin heart failure outcome trial, there was no increased risk. But again, as a class, SGLT2 inhibitors, always you have to be aware about what we call it euglycemic DKA, because most of them, they would have something like a normoglycemia, but they might manifest as a DKA. So as a class, you have to be aware that. But despite this, here in this study, we did not see an increase or safety signal in this one.
Last questions. The effect of DABA and heart failure. Is it for DABA or just class effect?
Well, I mean, now this is always the question that can we extrapolate this to other molecules in the class? I might not be very encouraging in extrapolating, but now we have got the evidence for dapagliflozin, and I think other molecules in the class, we are expecting to have the result very soon. Now, why I'm saying that we should not extrapolate this to others, because if you would see in the cardiovascular outcome trial, despite the same class, we have got a different benefits. So I might say, as explanation, it might be a class effect, but for evidence, in terms of evidence, we don't have except now for dapagliflozin.
Thank you, Dr. Saud, for your nice presentation and excellent discussion. I would like to extend my thanks to all my colleagues, my 4 senior colleagues, Dr. Walid Al-Bakr, Dr. Saad Al-Zahrani, Dr. Adnan Al-Sheikh, and Dr. Saud Al-Sifri. I enjoyed for the last 2 hours with this discussion in different topics under the umbrella of this excellent Congress, and I really appreciate the effort of Dr. Saud and Dr. Abdurrahman Sheikh and all of our colleagues in this meeting. We really get benefit, and even my colleagues from different specialty in endocrinology, they are even following this nice meeting, nice Congress since yesterday. All my best to all of you. Hopefully, inshallah, you will be in a good health, inshallah, all of you and our families as well. Thank you very much.
Can we ask that how many audience attendee تقريبا يعني حضر?
Maybe it's not clear for me here, but it would be in our colleague.
Okay. Thank you very much.
Thank you very much for all of you.
Thank you.